Hello, good afternoon. Nandito ulit tayo. Ito natin yung ating napanood kahapon, the explanation regarding congestive heart failure. O, di ba? So, kung hindi ninyo panood yun, just watch from here, yung ating part 1. At medyo mataas-taas kasi yung explanation ng isang YouTuber, Ninja Nerd. Shout out to you, Ninja Nerd. Thank you so much for a very simple explanation kung anong ibig sabihin ng congestive heart failure. Maya-maya ituloy-tuloy natin. But before anything else, let me welcome you to Bisda ko and Dude Sorda here. And also, magpasalamat na ako for those who subscribe and like my Bisda ko channel. And for those hindi pa like here, subscribe. So, hindi ko na masyadong i-review, no? Just watch the part 1 kung saan na-discuss doon ni Ninja Nerd. Ito talaga, ang galing niyang mag-explain ng reason or the patho, how do you call it, pathophysiology of the heart failure. Kaya dun sa part 1, tingnan nyo lang and see the description here. Isulat ko below yung part 1. Or actually, kung ayaw ninyong, gusto ninyo ng tuloy-tuloy, sandali. Kung gusto ninyo ng tuloy-tuloy panonood, you can click the full video of Ninja Nerd na nasa description below. Okay, sige. Just a short review. Ibalik ko lang yung video doon sa kanya. So here, bago ko i-play, mayroon na siyang illustration above. Ito yung part 1. Nakita ninyo sa pinakaitaas, the upper portion. Mayroong left, mayroong right. Yan yung reason as the pathophysiology kung bakit may tinatawag na systolic heart failure, mayroon din tinatawag na diastolic heart failure. Then the mga reason kung bakit magka-systolic heart failure, at the same time, yung mga reasons bakit matawag siyang diastolic heart failure. So, ang mangyari, both of these, as tulad nung naintindihan ko, both systolic or diastolic, ang kanyang cardiac output is still low. Okay? Now, ang diastolic is the left ventricle na dilated. Okay? So, and one of the causes bakit magka-systolic is the dilated cardiomyopathy. While on the other side, on the right side, diastolic heart failure, yan naman yung ang kanyang feeling. Okay? So, bali, yung feeling niya is mas marami, kaya magkakaproblema din doon. Anyway, just watch the full video or watch the part 1 of this live of mine. Sige, tuloy natin.
It increases aldosterone release from the adrenal gland, and it also increases, it's going to trigger hypertrophy. And guess what that's going to do? That's going to worsen their heart failure. And they're going to get sicker, and their heart failure is going to get worse.
Oh, excuse kung i-interrupt ko lang. Binalik ko lang mismo doon sa part kasi this is regarding blood pressure. Ang blood pressure kasi, the formula of the blood pressure is cardiac output times the systemic ventricular rhythm. Yun ba yun? Tama ba yun? Anyway, just correct me later if I'm wrong. So, ang mangyari, in-explain na niya tungkol sa blood pressure, tungkol sa BP. And medyo mahaba yun, na cover din yun ng part 1. Kaya dito, ito na yung portion na kung saan naipakita ni Ninja Nerd kung bakit mag-worsen. So the point here is that kahit systolic or diastolic heart failure, in the long run, magwo-worsen talaga ang scenario. So, ito yan. Okay.
The other thing it's going to do is it's going to constrict the veins. There's alpha 1 receptors on both the arteries and alpha 1 receptors on both the veins. So it's going to squeeze the veins and try to push a lot of blood back to the heart. And that's going to try to increase the preload. But then if you increase the preload, now the ventricles have to dilate to accommodate for that volume. And if the ventricle dilates, what does that sound like? Systolic heart failure. So it's going to worsen the patient's systolic heart failure. This is why it sounds like these things are kind of like a good mechanism to try to increase your SVR. That's what it's trying to do, is increase the SVR to increase your blood pressure, right? But unfortunately, it worsens the patient's heart failure and their heart rate. Another thing, if that wasn't enough, is this cardiac output's going to stimulate these like weird cells in the kidney, juxtaglomerular cells. And these juxtaglomerular cells are very sensitive to blood pressure. And what they'll do is they'll release a molecule called, you guys already know this, right? Renin. Release a molecule called. Now, renin will then, it'll then angiotensin 1 will then lead to formation of angiotensin 2. What's the enzyme that stimulates that process? ACE, don't forget that. Angiotensin 2 can do a couple things, but one of those things is it increases aldosterone release from the adrenal gland, and it also increases ADH release from the posterior pituitary. Now, with all of this being said, what's the overall effect of all of this? I'll show you. So here, let's say we have what's called a angiotensin 2 receptor here in your vessels. Guess what it does? Squeezes the heck out of them. What did that do? SVR goes up, because that's the compensatory mechanism. If SVR goes up, then what happens to your afterload? That goes up. What happens if you have diastolic heart failure? Worsen the hypertrophy. Patient's getting sicker. That's not helpful. What happens if you do to the preload? You're going to cause more blood to get returned to the actual heart. Preload goes up. But in a patient who has systolic heart failure, what is it going to do? It's going to dilate their heart even more and worse. So you guys get the concept here is that this is another potential problematic issue that can worsen the patient's heart failure. And that's why we have drugs that we'll talk about a little bit later that I'm going to kind of preemptively kind of covering here, that this will help to treat. Because we just don't want to have these high angiotensin 2 levels, the high sympathetic nervous system activity. And just to complete this concept, aldosterone and ADH will be higher. And you know what this does? This increases your reabsorption. Now the patient's reabsorbing lots of sodium and water. If you reabsorb sodium and water, what is that going to do? It's going to cause the patient to retain a lot of this fluid, and they're going to start developing edema. They'll have more preload, so the ventricles will have to dilate more. But one of the problems that you'll see here is they'll start developing a lot of edema because of this. So this is the concept that I really, really want you guys to be able to understand here with this nasty disease process. There's one more thing, which is actually super cool though. So this system here is called renin.
Okay, excuse kung i-cut natin ano, stop natin, I'm not cutting. Medyo mahaba na lang yung diniscuss niya. So at least nakita ninyo na along the process, talagang ma-worsen because of those na angiotensin 1, angiotensin 2 na mga dinidiscuss niya. What are those? That is part doon sa kidney naman. And then, from that, so talagang the whole system, the heart, the kidney, and everything, connect na sila. So, if the heart is not functioning well, later on, mapunta na rin doon sa kidney. Kaya, talagang mag-worsen dahil sa mga along the process, mayroong nangyayari doon. So, hindi na lang ako masyadong maging technical or medical terms kasi I am a patient. Okay. So, I just want to understand in the patient perspective, okay, kung anong ibig sabihin ng heart failure. So, sige, tuloy tayo.
angiotensin aldosterone system, right? You know, whenever your cardiac output's really low, another really interesting thing that happens is that your heart, whenever it's like really low cardiac output, the hearts actually kind of get filled with blood. And so they can release this molecule in response to a lot of stretch. So let's say that the heart is really, really, really being stretched. It's being stretched a lot. When the heart is being stretched a lot, it makes a molecule called atrial natriuretic peptide. And it makes a lot of it. And the whole point of increasing this atrial natriuretic peptide is it wants to go and inhibit. The hope is that it inhibits angiotensin 2. And if I inhibit angiotensin 2, I prevent this whole disastrous process from occurring. Well, that's cool. I would really like drugs that increase AMP then. I would really like drugs that decrease angiotensin 2, block aldosterone, and block the sympathetic nervous system. And that's what we'll talk about in the treatment section. But this is what I want you guys to understand about left heart failure. Now let's quickly go through right heart failure and high output failure. All right, my friends, so now we got to talk about right heart failure. So we talked about the left heart failure. The right heart failure is actually a lot easier. When we talk about right heart failure, it's the same kind of concept. We take this normal heart and we jack it up to cause systolic heart failure. Now, when we talk about this, it's again, you're dropping what? The contractility. So one generally drops contractility on that right heart. Well, in the left heart, the most common cause was an MI. Guess what it would be here, an MI, okay? So generally a right ventricular MI is going to be the most common cause, generally, of this systolic right heart failure. So you're dropping the contractility here, and that's leading to the formation of this systolic heart failure. Now, again, what you're going to notice is that this puppy is going to start getting super dilated, right? So what you're going to notice is this dilated type of right ventricle. Now, another concept here with this dilated right ventricle here is that your right ventricle, the contract.
Okay. So in this part, inexplain na naman niya yung on the right part of the heart failure kung ang right ventricle ang magkaproblema. So sa previous, inexplain lang niya both. Pero inuna niya yung reason doon sa left ventricle na heart failure. Kasi doon usually magsisimula sa left heart failure and then punta doon sa right ventricle ang heart failure. So ito na yung part na diniscuss niya.
Contractility is reduced, right? So this whole right ventricle, let's say, is really, really messed up. Because it's messed up, it's going to have a hard time being able to pump blood out into the pulmonary artery, right? So it's going to have a hard time with forward flow. So what you'll notice out of these patients is that they're going to have a low right ventricular cardiac output, right? Because of the contractility. And so because of that, they're going to have this low contractility. This is going to lead to a decrease in their right ventricular ejection fraction. Now, we don't generally give these, as we compared prior, the heart failure with the reduced ejection, it's primarily only consistent with left heart failure. Again, you can think about it in this particular way. But again, a reduction in contractility will lead to a reduction in the right ventricular ejection fraction. And the problem is that patients are going to have a hard time generating a cardiac output out of the right ventricle. And that's the concept here. It's pretty straightforward. Something is decreasing contractility because you infarcted the right ventricle.
Okay. Ini-stop ko lang dahil medyo may patalastas siya doon. Ayun, ulitin ko. Ayun, diniscuss na naman niya yung right ventricle heart failure. So, mayroon din palang makatuhan din ang ejection fraction. Natawag naman yung right ventricle ejection fraction. So, ang contractility, nandun pa rin yung contractility. Ibig sabihin contractility yung pag-push, okey? So, mahirapan ang pag-push. So, 'pag mag-decrease yung pag-push out ng dugo sa right ventricle, yung maapektuhan ang ano, so dun makikita yung ejection fraction kasi hirap niyang ibuga. Si tingnan natin kung puwede na ba tayong matuloy. Okey, sige. Tuloy natin. Pero bear with me kung paminsan-minsan may talaga natin to avoid copyright. But of course, shout out, thank you so much for Ninja Nerd. Kung hindi pa kayo nakapag-subscribe sa kanyang channel, subscribe. Ninja Nerd. This guy is really a nerd, ha? Especially kung yung mga ano, medical students. Talagang galing niya mag-ano. He is not a medical student, okay? He's not even a doctor. Talagang hilig lang niya yung regarding this topic. Kaya maganda tingnan, di ba? Okay, so let's continue. I-rewind ko lang ng konti ha.
Is that your ventricle, the contractility is reduced, right? So this whole right ventricle, let's say, is really, really messed up. Because it's messed up, it's going to have a hard time being able to pump blood out into the pulmonary artery, right? So it's going to have a hard time with forward flow. So what you'll notice out of these patients is that they're going to have a low right ventricular cardiac output, right? Because of the contractility. And so because of that, they're going to have this low contractility. This is going to lead to a decrease in their right ventricular ejection fraction. Now, we don't generally give these, as we compared prior, the heart failure with a reduced ejection fraction. It's primarily only consistent with left heart failure. But again, you can think about it in this particular way. But again, a reduction in contractility will lead to a reduction in the right ventricular ejection fraction. And the problem is that these patients are going to have a hard time generating a good cardiac output out of the ventricle. And so that's the concept here. It's pretty straightforward. Something is decreasing contractility because you infarcted the right ventricle. In the other aspect over here, you have something increasing the afterload, right? So if I have something increasing the afterload, in the example for left ventricle, it was hypertension, it was aortic stenosis. For this one, it's anything that increases, I'm going to put a little parentheses, anything that increases the pulmonary vascular resistance. So for the systemic circulation, it was called systemic vascular resistance. That was hypertension or aortic stenosis. And this thing, it's anything that causes pulmonary hypertension. So we say this is pulmonary hypertension. And there's different types. We'll talk about this in pulm when we go over pulmonary hypertension, but there's type 1, which is idiopathic, type 2, which is due to left heart failure, type 3 due to some type of like lung disease like COPD or interstitial lung disease, type 4 due to some type of chronic pulmonary emboli, and then type 5 is there's usually something like sarcoidosis, like something compressing the pulmonary vasculature. But this is the concept I want you to understand. Pulmonary hypertension for right heart failure, systemic hypertension for left heart failure for that diastolic type. Now, what do you notice here about this right ventricle? It's thick, right? So they have some hypertrophy.
Okay, kinat ko lang, stop ko lang ng sandali. I would just like to welcome those watching. Sa mga ngayon lang kapapasok, I am presenting here ang reason kung bakit magkaroon ng heart failure. Okay, heart failure is kung saan pa yung mahina ang puso. So this guy, Ninja Nerd, subscribe to his channel. In-explain lang niya dito. So medyo mahaba kasi ang explanation na to. Mayroon tayong part 1 which was yesterday. Just look back sa previous kahapon na live about this. And today is the continuation. And by the way, thank you for watching. Kung hindi pa kayo nakapag-subscribe, like, subscribe is the channel. Okay, sige, tuloy tayo.
Generally, of that right ventricle. So we could say right ventricular hypertrophy. And this is usually because that ventricle is going to have to thicken to be able to accommodate the high pressure of the pulmonary vasculature. That's the only way it can do it. And so because of that, it's going to have a hard time being able to fill with blood. So the problem with this situation here is the same concept. They have a reduction in right ventricular filling, which causes them to have again, a normal ejection fraction. They don't have a problem with their ejection fraction. So they have a normal right ventricular ejection fraction. So again, decreased filling process, but normal right ventricular ejection fraction. That's the big kind of thing that I want you guys to understand here. Now, again, remember, both of these are going to have a reduction in right ventricular cardiac output. It's just, again, the mechanism behind them developing this. All right, that covers this one for right heart failure, the pathophysiology and the causes. What about this weird? There's this weird entity called high output heart failure. And generally, high output heart failure is particularly only consistent with generally left, so the left heart. And what I want to do quickly is talk about this one. So for the most part, what you've noticed is that when we talk about left heart failure before, is that there was a low cardiac output. And then when you talk about right heart failure, there's a low cardiac output. There's this entity in the world where this is called a high cardiac output heart failure. You're like, what? That seems odd. It is weird, but here's let me kind of explain why this happens. In this patient here, we see that their vessels are super dilated. So they have extremely super vasodilated blood vessels. So what you'll notice here out of these patients is they have a massive vasodilation, all right? And when you vasodilate vessels, it's a big thing. We'll talk about what causes this, but this is massive vasodilation, all right? So there is massive vasodilation here. The question that you have to ask yourself is what's causing these vessels to become super, super dilated? There's a bunch of different things. One reason is very common is sepsis. Sepsis will cause massive vasodilation. Another one, which is an odd one, is when you have thymine deficiency, such as beriberi. This will, for some reason, cause massive vasodilation. Thyrotoxicosis, so when a patient has thyroid storm, this also cause
Well, medyo may mga underlying ano na siya ng mga sasabi kasi ito yung high cardiac output, okay? Kasi usually ang heart failure both left ventricle at saka right ventricle ang output niya is low tulad ng sinabi, but there is a particular exemption na wherein ang cardiac output is high kahit may heart failure. At ngayon, inano na niya yung mga, in-identify niya yung mga reasons or those mga conditions na bakit magka-high cardiac output failure. Okay? So, sepsis. Now, kung sinong may nakakaalam kung ano yung sepsis, medyo nakalimutan ko na, just comment below kung ano man yan. Then, nabanggit niya ang beriberi. So, isa yan sa maging dahilan. Okay? And then, ngayon yung sa parang thyroid ata to. So, sige, we'll just listen, continue listening this. Okay, balik ko lang ng konti.
Notice here out of these patients is they have a massive vasodilation, all right? And when you vasodilate vessels, a big thing, we'll talk about what causes it, but this is massive vasodilation, all right? So there is massive vasodilation here. The question that you have to ask yourself is what's causing these vessels to become super, super dilated? And there's a bunch of different things. One reason is very common is sepsis. Sepsis will cause massive vasodilation. Another one, which is an odd one, is when you have thymine deficiency, such as beriberi. This will, for some reason, cause massive vasodilation. Thyrotoxicosis, so when a patient has thyroid storm, this can also cause massive vasodilation. Other kind of interesting things could be things like AV fistulas, as well as severe, and I mean really, really severe anemia. These are particular things that in these diseases, but I would say sepsis being kind of one of the most common ones, these will cause massive vasodilation. When you massively vasodilate these vessels, what happens to the systemic vascular resistance? Now, sucker's huge. Resistance has got to be.
Se mai hai pensato che i business online sono una truffa, continua a guardare questo video. Questa è ad esempio una lettera arrivata.
Low. So now their systemic vascular resistance is crazy, crazy low. Now, go back to that formula. What was the formula called? For everything with low output heart failure, we said that we have blood pressure is equal to cardiac output of systemic vascular resistance. And all of the ones that we talked about, cardiac output was low, drop the blood pressure. Now, in this disease process, the systemic vascular resistance is low, which will cause the blood pressure to be low. What has to compensate? The cardiac output. And that's why we call this high output heart failure. So then what happens is when your systemic vascular resistance drops, what it does is it creates a reflex kind of situation here. So what it does, it'll drop the blood pressure. So the patient's blood pressure may drop. When you drop patient's blood pressure, what it's going to do is it's going to activate the sympathetic nervous system and the renin-angiotensin-aldosterone system, and that is going to increase the sympathetic nervous system. Now, look at this. If I increase the sympathetic nervous system, that's then going to go and work on the heart. And when it goes and works on the heart, it's going to work on a bunch of different components here. One is you have your SA node, your AV node, your bundles of His and bundle branches. That's all going to be activated. And your heart rate is going to try to go up because it's going to hopefully try to increase your cardiac output. And you're going to contract your heart like a son of a gun. So then on top of that, you're going to try to cause the heart to really contract and the stroke volume will go up. And both of these are going to be an attempt to try to push as much blood possible out of the heart. So what you'll notice is these patients will have a massive increase in heart rate and a massive increase in their stroke volume. But here's what's really odd. You would think, okay, these guys are pumping, and I mean pumping blood out of their heart into the coronary, into the systemic circulation. So the cardiac output has to be high enough, right? It's got to be good to be able to meet the actual tissue demands. It's not. And that's where the problem here in the cycle occurs. This disease causes vasodilation, leads to this whole process, tries to increase the cardiac output, but no matter what, it's not enough to meet the body's demands. And so what happens here is it's not enough. And that's the issue. So you see how when we talk about heart failure, it's the inability to perfuse the tissues and meet their demands. That would be a definition then. So high output heart failure is the cardiac output's high, but it's not high enough to overcome this massive vasodilatory effect to meet the tissue's oxygen demands. And that is heart failure. So far we've gone over left heart failure, low output, right failure, low output, and the rarity of high output heart failure. Now over what are the complications of a patient developing heart failure. All right, my friends. So now if a patient has left heart failure, whether that's diastolic or systolic.
Okay, so medyo marami-rami yun So ang naintindihan ko lang doon is that the blood pressure is equal to cardiac output multiplied by the systemic vascular resistance, no? Na-explain niya doon kung paano. So ang mangyari kung low ang cardiac output, of course the blood pressure is low, pero magdepende rin kasi kung may problema din katulad ng mga nabanggit niya na mga underlying conditions, magkaroon naman din na hindi ko masabing complication but medyo nadagdagan yung tinatawag na high output ng failure ng cardiac failure ng heart failure. Okay, sige, wag na lang natin masyadong i-memorize yun lahat. Importante nagkaroon tayo ng idea kung bakit maging gano'n dahil may namamaga. So kapag namamaga, magka-problema yung output at saka input ng dugo sa ating heart. That's my simple way of saying it. Okay, tuloy tayo. Again, thank you so much for watching ha. Please don't forget to like, subscribe. By the way, ngayon, inaano na niya yung mga symptoms. This is very important kasi as patient, katulad ko, mas makarelate ako nito kung yung mga symptoms kung bakit. Kanina kasi, that's more on medical terms. Eh. So ito, symptoms, ito yung makikita natin sa ating katawan. Kaya mas madali natin itong maintindihan. And so let's listen to this.
Heart failure or right heart failure, there's systolic or diastolic heart failure, we have to understand the particular complications that can arise. When a patient has left heart failure, one of the big things that you'll see with these patients, features of pulmonary congestion. So either way, the patient's cardiac output stinks. They're not able to get enough blood out of their left ventricle. So what happens is, because they have a cardiac output that is being reduced, if you will, in other words, these patients, it's hard to get the blood out of the heart. Because of why? Because they have a reduced cardiac output. Now, because of that, if the blood can't get out of the heart, where's it going to go? It's going to start backing up into the left atrium. When it backs up into the left atrium, it goes into all of these like cute little pulmonary veins here. See, it starts moving into the pulmonary veins. And then what happens is it starts kind of like congesting these pulmonary veins intensely. Now, when the pulmonary veins start coming very filled with all of this blood, the pressure in those go up. And we use a terminology here called pulmonary capillary wedge pressure. So we use that on both of these here. And this will go up. And the pulmonary capillary wedge pressure is a measure of left heart pressures. So if the left heart pressure is high, the pulmonary capillary wedge pressures will also be high. When that happens, the pressure in the pulmonary capillaries rise enough that guess what starts leaking out of this actual vasculature? Fluid. So you're going to have fluid leaking out of this vasculature and into the interstitial spaces and into the alveoli. So now this alveoli is going to be filled with fluid. You're going to develop some edema here in the interstitial spaces. And now these patients have pulmonary edema. And so this is one of the potential complications is they get a little bit of pulmonary edema. Now, why is that bad?
Okay, so inano na niya yung first symptoms, yung tinatawag na pulmonary edema. So yung mga mamamaga yung pulmon, di ba? Dahil, bakit mamamaga? Dahil yung hindi makalabas yung dugo kasi hirapan ngang i-pump out ng left ventricle. Kaya ang mangyari, kung hindi niya mailabas lahat, magpapasok, sobra. So, aapaw. So, saan na mapunta? Mapunta doon sa lungs. Magsimulang mamamaga din yung lungs kasi yung dugo mapunta din doon. So, ito yung, kaya dito din makikitang mahirapan huminga yung pasyente, yung mayroong heart failure. So, this could confirm, pero fortunately, I thank God na sa ngayon naman, based sa aking mga clinical result, hindi pa naman umapaw din doon sa lungs. Yeah, it's a good thing. Pero, of course, sabi na nga, still, we have to prepare. I have to prepare.
When you have pulmonary edema, some patients can present a couple different ways. One is they particularly present with what's called dyspnea. Now, dyspnea, it may just be a generalized dyspnea. This may be with exertion. This may be rest. That depends upon the severity of their CHF. But another very interesting presentation is that whenever these patients lie flat, the fluid tends to kind of separate out into multiple parts of the lungs. Normally, they'll be in the dependent inferior portions. But as you lay flat, this edema can become worse and spread throughout multiple alveoli. And this can worsen their actual shortness of breath when they're laying flat. And so there's two terminologies. One is called paroxysmal nocturnal dyspnea. This is whenever they're asleep and they're laying flat, they're super short of breath. Or just in general, maybe they're not sleeping, they're laying down flat or laying on a recliner, and they have some shortness of breath there. It's the same concept. It's called orthopnea. These are big common features that we see with pulmonary edema. One is just dyspnea, big rest, or the other one is when they're laying flat.
Okay, so dyspnea, yan yung parang shortness of breath, no? Breathlessness. Okay. So this is one of the symptoms, yung nakalying flat ka, para kang kulang ng hininga. Okay, so yun yung sinasabi niya. Dahil doon sa yung lungs dahan-dahan ay nagkaroon ng edema, hindi sa namamaga, na do you call it, na fill in siya nung something liquid, which is of course the blood. Kaya yun, dyspnea. Tama ba yung aking pag-pronounce? So tuloy natin.
In the interstitial spaces, and now these patients have pulmonary edema. And so this is one of the potential complications, is they get a little bit of pulmonary edema. Now, why is that bad? When you have pulmonary edema, some patients present a couple different ways. One is they particularly present with what's called dyspnea. Now, dyspnea, it may just be a generalized dyspnea. This may be with exertion. This may be at rest. That depends upon the severity of their CHF. But another very interesting presentation is that whenever these patients lie flat, the fluid tends to kind of separate out into multiple parts of the lungs. Normally, they'll be in the dependent inferior portions. But as you lay flat, this edema can become worse and spread throughout multiple alveoli. And this can worsen their actual shortness of breath when they're laying flat. And so there's two terminologies. One is called paroxysmal nocturnal dyspnea. This is whenever they're asleep and they're laying flat, they're super short of breath. Or just in general, they're not sleeping, they're laying down flat or laying on a recliner, and they have some shortness of breath there. It's the same concept. It's called orthopnea. These are big common features that we see with pulmonary edema. It's just dyspnea, exertion and rest. The other one is when they're laying flat, paroxysmal nocturnal dyspnea or orthopnea. Huh? Another potential problem here is that whenever these patients, let's say they really have a massive reduction, say that their cardiac output massively reduces, maybe for whatever reason. Common triggers for patients to develop what's called acute decompensated failure is they have an MI, or they have a massive tachyarrhythmia, or they stop taking their medications they're supposed to be taking. And what this does is this massively drops the cardiac output, massively increases the pulmonary capillary pressure, and worsens their pulmonary edema, like terribly. And sometimes this pulmonary edema can be severe. I'm talking severe pulmonary edema. And this is something that we would generally see when a patient has what's called acute decompensated heart failure. And what happens is this fluid will really start kind of like all over multiple different alveoli, and interstitial spaces will become filled with fluid. And this can cause a massive VQ mismatch. When you fill up multiple alveoli with fluid, that causes a VQ mismatch. Decrease in ventilation, normal perfusion, the mismatch, and that leads to hypoxemia. So watch out for a VQ mismatch here. And what will happen is the patient's SpO2 will be very low, and they can exhibit features of what's called hypoxia. Other thing is that this fluid that leaks into the interstitial spaces, when it actually does leak there, sometimes it may just cause the patient to have generalized dyspnea or increased work of breathing. So they may be working hard to breathe, or they may have a higher respiratory rate. So that's another kind of thing that you want to watch out for, is watch out for an increased work of breathing or an increased respiratory rate. So these are some of the big findings that you want to watch out for. So again, watch out for a stimulation of VQ mismatch because of all of these alveoli being filled with fluid, and then hypoxia. So watch their O2 sat to see if they have desaturations. This is super, super common in left heart failure. So big things to look out for is go to the patient, see if they have any respiratory distress or hypoxia on their O2 saturation. Ask if you have any shortness of breath at rest, exertion, or laying down flatter when they're sleeping. The other thing, get your stethoscope that you paid so much money for and go and listen. And if you hear any rails or crackles, all of these are potential signs of pulmonary edema. This is very common in left heart failure. The scariest complication that I say that you would potentially see in a patient who has left heart failure is cardiogenic shock. And this is definitely the scariest one. Generally, again, a very common trigger here that can happen is an tachyarrhythmia, or you stop taking your medications. These are very, very common triggers. Now, again, same concept. The patient has a massive drop in their cardiac output. If you drop their cardiac output,
Okay. Stop ko lang ng sandali. So, ngayon mag-proceed na siya sa next symptoms na according to him medyo dangerous. Well, of course, pati naman yung bila, yung edema, kasi pulmonary edema, ano din yun. Pero yung mga symptoms doon, sinasabi niya is yung hingal, hirap huminga, okay? Lying down, hirap huminga, kahit nakatayo paminsan, magkulang ng hininga, shortness of breath. And then, meron pang isang kung sakaling lalala, magkaroon ng yung tinatawag na parang bababa din yung oxygen. Kaya of course, siyempre, related din siya doon. The next here, ang inano niya na symptoms is tinatawag na cardiogenic shock. Okay, panoorin natin paano. And by the way, if you know someone na mayroong heart failure or inang po, you could refer this link in Ninja Nerd to understand better. Sige.
You're not going to be getting enough blood flow. The scariest complication that I say that you would potentially see in a patient who has left heart failure is cardiogenic shock. And this is definitely the scariest one. Generally, a very common trigger here that can happen is an MI, a massive tachyarrhythmia, or you stop taking your medication. These are very, very common triggers. Now, again, same concept. The patient has a massive drop in their cardiac output. If you drop their cardiac output, you're not going to be getting enough blood flow out of their heart. When you don't get enough blood flow out of the heart, particularly enough volume, you drop that cardiac output, what happens to their perfusion? Oh, that's stinky. That systemic perfusion goes down. So not only whenever you have a low cardiac output, do you have a hard time getting blood out of the heart and it backs into the lungs, but you have a hard time getting it out of the heart and delivering it to multiple tissues. When you have a decrease in systemic perfusion, the problem with this is that your body kind of says, okay, perfusion's kind of stinky right now.
Okay, i-add ko lang doon yung symptoms na arrhythmia. Banggit niya yung arrhythmia. So, dapat talaga hindi malimutan yung pag-take ng gamot para iwasan ito dahil tulad ng sabi niya, this complication is a bit risk. Okay, kasi yung magka-create ng tinatawag na cardiogenic shock. Okay, so arrhythmia, na-experience ko yan. Arrhythmia, yun yung irregular heartbeat. Okay, irregular heartbeat, yung siguro palpitation, lalakas. Yun yung arrhythmia. And I have a medicine on that. Meron akong medicine na tinitake. Anti-arrhythmia naman siya na medicine na magpapalow ng beating instead para ma-compensate niya, para mawala yung pag-beat ng mabilis. In fact, yan nung last July na for I think 2 weeks in-stop nila yung anti-arrhythmia na medicine na yun. Then after ako umalis sa hospital, nabalik agad na nabalik na naman ako dahil hindi maiwasan na nagka-arrhythmia doon. So, ibinalik ulit yung medicine, yung medicine yun na tinitake, anti-arrhythmia. So, yan yun. Isa sa mga symptoms ha. Kaya huwag kalimutan.
That's because the output's really low. You know what the body tries to do is it says, okay, what I'm going to do is, if the cardiac output, what's that formula? BP is equal to cardiac output times the systemic vascular resistance. Let's write that out. So BP is equal to cardiac output times the systemic vascular resistance. And these patients who are in cryogenic shock, this is low, causing this to be low. What has to compensate, my friends? SVR, and this will shoot through the roof. And when SVR goes up, it clamps down on vessels, squeezes them. And now you have very little blood flow going to your extremities. You know what this is going to do? This is going to cause these patients to have very cold or pale extremities. Another really, really terrifying sign here is they have like mottling. And this is really, really kind of scary. It's where they have this weird kind of discoloration, usually at the knees. And that's a very it's a very poor sign of perfusion. And this is usually because you're clamping down on those vessels to compensate. Another thing is that when you have decreased systemic perfusion, not only do you create this reflexive vasoconstriction, but you also get organ malperfusion, right? If I have organ perfusion, oh man, that ain't good, because now I'm not perfusing various tissues. What are some of these tissues that actually become affected because of an increase in more organ malperfusion? One is the
So, sorry to interrupt. Nagkaroon lang tayo ng technical problem. Medyo mahina yung ating linya. Kaya i-stop ko na lang din dito for the meantime kasi marami-rami na rin yun siyang diniscuss. So, uh, review ko lang tungkol sa symptoms, yung edema, pamamaga. Okay? So, dyspnea, yung shortness of breath dahil nahirap nang ibuga na yung dugo kaya mag-overflow dun sa pulmon, kaya magkaroon ng pulmonary edema. At isa din yan sa rason bakit hinihingal ang isang taong mayroong heart failure. And then the next one is yung arrhythmia, no? And pag magka-arrhythmia, yun ang ano din ang mahirap dahil magkaroon ng sinasabi niyang complications, and kaya paminsan yung extremities daw, lalo dun sa paa, yung sinasabi niya dahil yung perfusion ng mga pinasasabi niya is maging mahina din dahil yung cardiac output maging mahina din. Cardiac output paglabas ng dugo. So ang mangyari sa extremities like doon sa paa, malamig or iba ang kulay. So ayan, those things are mga na-experience ko din yan. Nagkaroon lang, hindi ko lang maano yung mga terms, but now medyo naliwanagan tayo. So better to understand it para hindi tayo masyadong mag-panic. Ano? So dito na lang tayo. Maraming salamat for watching Bizda ko. Tuloy po natin yung ano na yun kasi mahaba din naman. And I hope you have learned something ng sharing na to. And if you want see my uploaded videos, mayroon tayo doon kung yung aking mga symptoms, aking daily movements, and yung especially now na nandito tayo sa screening process for heart transplant. So doon may mga sharing, although it's not really like this na very in-depth, no? Kundi ano lang, patients perspective sharing yung mga experience ko having this heart failure, dilated cardiomyopathy with low ejection fraction. Okay, so thank you again. Don't forget to like, subscribe to my Bizdaco channel. Share. Bye-bye.